So welcome everyone as you're coming in. My name is Tracy Comans. I'm Director of the National Ageing Institute, and welcome to our Seminars in Ageing program today. I'd like to begin by acknowledging the traditional owners on the land on which we are meeting today. For me, in Parkville, Melbourne, that's the Wurundjeri Woi-wurrung people. I'd like to acknowledge the traditional owners of the lands and waters across Australia and pay my respects to elders past and present and to all Aboriginal and Torres Strait Islander people. Firstly, a little housekeeping regarding our Teams meeting today. The chat function is turned off, but you can access the Q&A button. If you look on the top menu of your screen, you should see that button in the middle with the little question mark. So please feel free to post in questions as we're going along today. And at the end of the seminar, we'll be able to ask a few of those questions. So we're going to record today's session and it will be uploaded to our website in a few days. So please keep this in mind if you do turn on your audio and video to ask a question. It's a real pleasure of mine to introduce Associate Professor Penny Mackenzie today, who's the Director of Radiation Oncology at the Royal Brisbane and Women's Hospital. And if you're joining us today, you've probably already seen her impressive biography. So I wanted to tell you a little bit more about Penny. So I had the privilege of being part of Penny's PhD supervisory team, and today she'll be presenting some of the work that came from that research. And I should warn Penny that I'm about to embarrass her because she's one of the most modest people I've ever met. Penny is one of those people who combines academic excellence, clinical expertise, and genuine kindness. She's generous, gracious, and was an absolute pleasure to work with. And she was also an exceptional PhD student, one of those students who always seemed to be a step ahead. And indeed, she finished her PhD well before the due date and had to wait to submit it. She made supervision so easy. I think my main contribution was turning up to meetings and admiring what she'd accomplished since the last one. When we talk about healthcare, we all hope that if someone we love becomes unwell, they'll be cared for by a doctor who's not only highly skilled, but who also sees them as a person. Penny is exactly that kind of doctor. She's one of the really great clinicians, and you'd feel reassured if knowing that your parent or grandparent or older friend was in her care. Today, she'll be talking about geriatric oncology and the important role of radiotherapy in caring for older people with cancer, an area where she's made significant contributions through both her clinical leadership and research. So please join me in welcoming Associate Professor Penny Mackenzie.
Thanks so much, Tracy, for that very kind introduction. As Tracy mentioned, I'm a radiation oncologist based in Brisbane. I had the privilege of doing a PhD, and I had a wonderful supervisory team, and Prof Comans is one of my research supervisors, so I was able to learn a lot from everyone during this journey. So very excited to be able to share some of this knowledge with you today. So I thought we'd start a little bit on the definition and epidemiology of geriatric oncology, why it's important, a little bit on radiotherapy utilisation and current research in this area, and future work and opportunities. So what is geriatric oncology? So it's a relatively new term and refers to the older cohort of patients with a diagnosis of cancer. The specific age is variably defined in literature. The National Comprehensive Cancer Network, which is a US-based clinical guideline, state that there's no chronologic age threshold to define an older adult. And the International Society of Geriatric Oncology, which is the peak international geriatric oncology group, describe older adults as patients aged 70 years and above. For my research on geriatric oncology and radiotherapy utilisation, we selected 80 years and above based on the average life expectancy of a patient in Australia. But this is also the age which the radiotherapy treatment paradigms often change. In terms of epidemiology, the increase in the ageing population is well documented. The Australian Institute of Health and Welfare also report an increasing incidence of cancer with increasing age. We also have data from overseas, so data using the American SEER database. Weir et al. Have presented and published this research demonstrating a greater than twofold increase in cancer incidence in patients aged 85 years and above by the year 2050. In terms of why it's important, So a significant portion of the patients that we review in clinic are older adults with medical comorbidities and associate frailty. I've just been in clinic this morning. I reviewed 2 older ladies with breast cancer and an 86-year-old lady with breast cancer. So this is part of our day-to-day clinical care. So as part of the initial consultation, it's very important that the clinician assesses an older patient and provides appropriate treatment recommendations, but also minimises over or under treatment and incorporates the patient preference in the decision-making process. Treatment strategies need great consideration in balancing local control and survival with the tolerance and toxicity of treatment. It is, however, sometimes difficult. Ageing is heterogeneous and older adults are underrepresented in clinical trials. There are, however, various clinical-based decision tools that can assist with patient assessment and management decision-making processes. So some of these tools include the NCCN guidelines, the Comprehensive Geriatric Assessment Score, and geriatric screening tools, and we'll discuss all these in turn. So this is the NCCN. They have a special section on older adults with cancer, and I find this page quite informative and especially assisting with our junior colleagues. So decision making and suitability for the treatment and also based on a patient's life expectancy. So one of the first branch points that you can see is a patient a candidate for cancer-specific treatment considering their life expectancy? And if the answer is no, appropriate symptom management and supportive care and referral to palliative care team, or yes, does the patient have decision-making capacity? Do they understand the relevant information, appreciate the situation, are able to make a decision and communicate their choice, and then further branch points based on this? It's very important that we provide appropriate assessment for patients, so geriatric assessment and management prior to treatment recommendations. And this has been emphasised by all the peak international oncology groups. This is a position paper published by ESMO and CEOG. So ESMO is the European Society of Medical Oncology, and CEOG, the International Society of Geriatric Oncology, demonstrating the importance of geriatric assessment and management prior to treatment commencement for older patients with cancer. And these are some of the domains that it's important that we assess in older patients with cancer. So we need to assess their functional status, and there's various tests that can be performed during clinic. One's a timed up and go test, whereby you ask a patient to walk a certain distance and then return back to a specific position on the floor, and you can time that. Comorbidity, assessing a patient's comorbidity status, the Charlson Comorbidity Index, as well documented in the literature. There's many other comorbidity scores as well that can be used. A patient's social functioning supports are very important. We are concerned with patients that are socially isolated. We're lucky to work with a large multidisciplinary team, so we can provide appropriate support for these patients. It's important to assess a patient's cognition. There are many tests that can be done for this, including the mini-cog. Psychological status. Anxiety and depression is common in the community. We have an increased risk of anxiety and depression in patients with cancer, and also an increased risk in older adults. So it's important that we assess this. Nutrition and polypharmacy, and referral to a pharmacist to assist with this. So these are the important domains that we need to assess for our older patients with cancer. In terms of a comprehensive geriatric assessment, so this is a gold standard assessment for older patients prior to cancer treatment. This is to allow a complete assessment of the medical comorbidities and of functional status, and thus suitability for cancer treatment. It's endorsed by the peak international oncology group, so the European Radiotherapy Society, NCCN, CEOG, and the American Society of Clinical Oncology. And it's thought that it provides further information than the initial widely used ECOG performance score. ECOG performance score was first published in 1960. We do have level 1 data that a comprehensive geriatric assessment prior to the commencement of treatment does improve quality of life, decreases significant toxicity, so grade 3 to 5 toxicity, with 5 being death, decreases unplanned hospital admission, and decreases discontinuation of planned treatment. This data currently is in the systemic therapy area. In terms of comprehensive geriatric assessment, this is actually not routinely used in many cancer centres in Australia and overseas because it can be time consuming and there's resource limitations. So there are other screening tools that we can use. So this is the evidence for the comprehensive geriatric assessment. The first trial there in the first column, Integrate, this is actually a study by Keng So. Keng's a dual-trained medical oncologist geriatrician based in Melbourne. Keng's done some great work in this field, and he looked at patients aged 70 years and above, about to start systemic therapy, and looked at patients that received CGA or not a CGA, and patients that had a comprehensive geriatric assessment prior to treatment. There was improved quality of life, decreased unplanned hospital admission, and decreased discontinuation of unplanned treatment. So comprehensive geriatric assessment is very important. However, as mentioned before, resource limitations, time consuming, it can be difficult to implement routinely. So often clinicians are using screening tools, and the G8 is one such screening tool. And this was recently incorporated in the EverQ platform, as you can see on the document on the right there. So the EverQ is our national radiotherapy protocols, and it's funded by the New South Wales government. So the G8 screening tool is a clinical questionnaire that assesses 8 domains. And if a patient has a score of less than or equal to 14, a geriatrician referral is recommended for a CGA. So the G8 is recommended by COG as a preferred screening tool. And we also have data that it can give prognostic value in determining treatment-related complications and overall survival. So the G8 looks at food intake, weight loss, mobility, neuropsychological problems, BMI, medication history, and patient's general health status, and also age. So coming to radiotherapy, so a patient's being diagnosed with cancer, an older adult, we're taking into consideration their full medical history, including medical comorbidities, functional status, geriatric screening tools. But in terms of treatment, so radiotherapy is an important component of the treatment options for older patients with cancer. It's non-invasive in comparison to surgery, and generally does not have systemic side effects in comparison to systemic therapy with chemotherapy, immunotherapy, or biologic therapy. So it can be well-tolerated treatment. In general, for radiotherapy, however, we know that the radiotherapy use or utilization rate decreases with increasing age. So in terms of radiotherapy use or utilization, patients following a diagnosis of cancer, we do have data that approximately 50% of patients would benefit from radiotherapy for a local control survival or symptomatic benefit from radiotherapy. So my initial work on radiotherapy and utilization for older patients with cancer was looking at what proportion of patients actually receive radiotherapy. We were concerned it might be less than the optimal or recommended rate for radiotherapy for these patients. We looked at this in adjusting for comorbidity status, and the actual rate of radiotherapy was less than the optimal rate. And I'll come a few more slides on this in a moment. So some of our research, so we looked at developing an optimal radiotherapy utilization rate. So New South Wales Cancer Registry data was linked to radiotherapy data and hospitalisation data to determine the amount of patients that receive radiotherapy, so the actual radiotherapy utilization rate. We also determined a comorbidity score. We used the C3 comorbidity score, which is based on a cancer-specific comorbidity score developed by an epidemiologist in New Zealand, Professor Diana Safati. And then from this, we developed an optimal age and comorbidity adjusted radiotherapy utilization rate. So for an older patient, based on their age and medical comorbidities, what would be the recommendation, or what would be the appropriate recommended radiotherapy utilization rate for this cohort of patients? As you can see the data on the right there, so the non-age specific radiotherapy utilization rate. So for all patients, non-age adjusted 48%, but some of the initial research for my paper, so patients aged 80 years and above, only 14% of patients receive radiotherapy versus patients aged less than 80 years when 28% of patients receive radiotherapy. So a little bit more of the details. So looking at the New South Wales data, so local data, which is the graphic on the left, and you can see that the radiotherapy utilization, which is the y-axis, the trend for radiotherapy use or utilization decreases with increasing age across the different tumour sites, so lung, breast, and rectal, except when patients receive radiotherapy instead of surgery. So when radiotherapy is used in the definitive setting, such as for patients with prostate cancer, and then the radiotherapy utilisation rate does increase before further decreasing with increasing age. We also looked at the global data and I formed a systematic review, but the trends were similar. So for increasing age, the radiotherapy use or utilisation rate decreased, except where radiotherapy was used in the definitive setting, such as for patients with prostate cancer as a surrogate for surgery. In terms of the overall data, so we looked at a number of different tumour sites, so the most common tumour sites in Australia, and looking at what proportion of patients receive radiotherapy or the actual rate, and what proportion of patients should have received radiotherapy after the optimal rate was adjusted for that age and comorbidities. So this data is for patients aged 80 years and above, and using, again, the New South Wales data sets. So for patients with breast cancer, 25% of patients with a diagnosis of breast cancer received radiotherapy versus 84%, which was the optimal rate. And looking across to non-small cell lung cancer, which is the second column across. So 25% of patients aged 80 years and above with non-small cell lung cancer receive radiotherapy versus the 49%, which is with the optimal radiotherapy utilisation rate after adjusting for that age and comorbidities. So you can see there's still a shortfall between the number of patients that receive radiotherapy and the number of patients that should receive radiotherapy for a local control survival or a symptomatic or a palliative care benefit. So why is there a gap between actual and optimal in terms of the radiotherapy use? It's thought to be multifactorial. Could be potentially related to ageism, and that's both clinical and patient ageism. Also, patients inappropriately not receiving radiotherapy treatment. Also, minimal training in geriatric oncology across all these specialty disciplines, and patients being underrepresented in clinical trials. So what's needed to further evaluate the causes of reduction in radiotherapy with increasing age? We need more data. We need prospective data. We need patterns of care data. We need data on including comorbidity, functional status and performance status data embedded in these clinical trials. CEOG, so the Peak International Oncology group, published a policy review paper a few years ago now in the Lancet Oncology, highlighting 4 areas of focus for the management of older patients with cancer. These were education, clinical practice, research and collaboration and partnership. So I thought I'd just discuss a few research projects in the next few slides. So underrepresentation in clinical trials. So we support high quality, safe, evidence-based care for all of our patients. However, older patients are typically underrepresented in clinical trials where the eligibility criteria is patients aged 18 to 70 years of age. So older patients should be a focus of research rather than excluded or underrepresented in clinical trials to ensure that our workforce is able to provide high quality, safe, evidence-based care for all. And what can we do to improve this, and what are the barriers and enablers for this? So in terms of enablers, I've listed a few here, and staying positive, these could potentially be listed as either, but we need to broaden inclusion criteria. We need geriatric oncology specific research. We need to also include geriatric assessment and measures of comorbidity and frailty status as part of these clinical trials, and also incorporate quality of life measures in the trials. So appropriate trial design, aiming to attain more research grants, particularly to assess older patients with cancer, and also improving education around geriatric oncology, including geriatric oncology as part of our policy statements, and also using the wealth of knowledge and expertise that's available in real-world data, so electronic health medical records and national databases. In terms of barriers, funding's listed there. Physician reluctance in terms of potential toxicity with treatment of older patients. Patient ageism. Patients think that they might be too old for treatment, and caregiver availability. So in terms of enablers, geriatric oncology specific research is very important. As mentioned, this is a relatively new area of cancer care, but by having geriatric oncology specific research, this will enhance the medical knowledge and skills of the entire cancer care team during these clinical trials, with education provided around the trial, and ultimately translate to better outcomes for patients. And there's more and more data in this area. In terms of geriatric oncology specific research, this is limited and it's not in all tumour sites. We do have some tumour sites with geriatric oncology specific research, and I'll discuss a couple of trials for patients that have early stage breast cancer. In terms of current trials and literature, so this is a PRIME2 study. It was a UK-based trial with initial data presented in Lancet Oncology in 2015. So they randomised more than 1,000 patients following breast-conserving surgery to either radiotherapy treatment and endocrine therapy or endocrine therapy alone. So patients with early stage breast cancer, no negative disease, good prognostic tumours in terms of ER positivity. So looking at radiotherapy and endocrine therapy or endocrine therapy alone. The results of this were updated a couple of years ago now in the New England Journal of New Medicine, which demonstrated no difference in overall survival comparing radiotherapy and endocrine therapy versus endocrine therapy alone, although the 10-year local recurrence was better with radiotherapy. So 0.9% of recurrence with radiotherapy versus 9.5% with endocrine therapy alone. We do know it's obviously important to review the details, the patients, and also the details in the trials. So the 10-year local recurrence without radiotherapy was also much higher in the cohort of patients that had ER low disease. So estrogen receptor status is an important prognostic factor for patients with breast cancer. So looking at patients in a slightly higher risk group. So being mindful of this as part of our treatment recommendations. But also drawing your attention, again, this is still the PRIME2 study that we've just discussed, but in terms of their methodology and incorporating geriatric specific measures or quality of life measures as part of the treatment. So they did not request specific details of performance status or documentation of comorbidities. So sorry, it's got that covering that area there. I'll just pull that down. So did not request details, specific performance status or formal documentation of the comorbidities. So areas that we need to improve on, improving the methodology to assist with management of older patients with cancer, and assist with subgroup analyses and provide further granularity on the health status of older patients. But we are improving. So this is a more recently published paper, and this is also presented at the European Radiation Oncology Conference this year in Stockholm and published in the Lancet last year. So this is a trial, again, looking at ladies with early stage breast cancer after breast conserving surgery, but they incorporated the G8 screening tool in the trial. So it was incorporated as part of their trial design. So randomization stratified by health status according to the G8 screening tool and by age, so 70 to 79 years and 80 years and above. And we do have preliminary results of the study. So this is patients breast conserving surgery, then they had endocrine therapy or radiotherapy versus both treatments together. So at 24 months, endocrine therapy was associated with a greater reduction in health-related quality of life compared with radiotherapy. So radiotherapy was better tolerated compared with endocrine therapy, but we're still awaiting more mature data on local control rates. And the co-primary endpoints that were pre-specified for this study were local control and quality of life. But they looked at quality of life across a number of different domains. So this is a very interesting study for patients. And in terms of what happens practically in the clinic, older patients with early stage breast cancer are often referred for radiotherapy versus endocrine therapy because we know in the clinic the toxicity can be higher with endocrine therapy. So this is for patients with early stage breast cancer. In terms of other enablers, really important, as always, is education. So education around geriatric oncology. We do have data. Tim Toes, palliative care physician in Adelaide, he published a survey which demonstrated less than 20% of medical oncologists use geriatric screening in routine clinical practice. So this is data that's a little bit old now. I'm not sure what the percentage for radiation oncologists is. I expect it's a little bit less than that. So Lucinda Morris, Lucinda's a radiation oncologist in Sydney, is doing great work in the field of geriatric oncology and education, particularly for radiotherapy. So we're trying to we have had this incorporated into the college curriculum. So for our advanced trainees in radiation oncology, this is part of their curriculum and expected knowledge for their fellowship exam. So I think that's great that we're incorporating this as part of routine teaching and training now. In terms of other enablers, geriatric oncology civic research committees. I'm fortunate in Queensland to be involved. Cancer Alliance Queensland, we have a specialist geriatric oncology committee which is doing great work. We've recently developed an electronic frailty index so that if patients' cases discussed in a multidisciplinary team meeting, we can have that information there ready to go to assist with clinician decision-making processes. It's also important that policy statements include the care of older patients with cancer. It's certainly a priority area in terms of the Australian Cancer Plan. So the Australian Cancer Plan aims to improve health equity for older Australians. And oncology in terms of medical oncology and radiation oncology and surgical oncology was all included in the optimal care pathway, which is recently updated for older adults. So other enablers, other trials that can assist with treatment access for patients. So we know it can be hard for patients coming in for treatment. Access can be difficult, especially when caregiver availability is limited. So this is another UK-based study comparing 3 weeks of radiation versus 1 week of radiotherapy, initially published in 2020, but updated data published this year. So in terms of the trial, so more than 4,000 patients randomized to 15 treatments or 15 fractions, so 3 weeks, so 5 treatments a week versus 1 week of treatment. There's just 2 slightly different dose fractionation schedules there, but 5 treatments in 1 week. Patients aged 18 years and above. So it's not just including the low risk case in this trial. It's not just T1, T2 now. Larger tumours are included, and patients may have undergone breast conserving surgery or a mastectomy procedures. This is a large study. In terms of the interim results at 5 years, excellent results in terms of ipsilateral breast tumour recurrence, so a low risk of a local recurrence with a 1 week course of treatment and non-inferior to the 3 week course of treatment, and excellent cosmesis in both arms. But the results were also updated at the European Radiation Oncology Conference this year, and there was a simultaneous publication in Lancet Oncology comparing this 1 week versus the 3 week regimen. And the 1 week regimen was non-inferior to the 3 week regimen. The regimen that we're clinically using in practice at the moment is a 26 grain 5 fractions to 27 grain 5 fractions, thought to have a slightly higher risk of side effect profile, but non-inferior 5 treatments compared to 3 weeks of treatment in terms of ipsilateral breast tumour recurrence. So for older patients coming in for treatment, 1 week of treatment versus 3 weeks of treatment is a significant difference. So in terms of future work, we need to have a multidisciplinary approach to cancer care for older adults. We need to have involvement of relevant stakeholders and ongoing education of health professionals, and of course adequate funding and resources. But I'm very lucky to have been well supported in my research and clinical journey today. And thanks again, Tracy, for all your assistance as a wonderful PhD supervisor and mentor and inspiration to me. And also thank the research groups I've had the opportunity to work with. So UNSW, C-Corp, which is Sydney-based research group, and also the Cancer Alliance Queensland. So thank you very much for listening, and happy to take questions.
Great. Thank you very much, Penny. If you'd like to ask a question, please raise your hand, or you can put a question in the Q&A. I think you can stop sharing, Penny, maybe, because we've got that. Thank you. I just might start, and I was sort of thinking when you put up the differences in people over 80, receiving radiotherapy compared to under, and there's a number of factors that might cause that, one being ageism, but I'm wondering, has anyone looked at other vulnerable groups, for example, CALD, and do you see similar patterns in terms of utilisation that you might be able to sort of draw parallels to?
Yeah, look, I think the interesting in this area, Tracy, is there hasn't been much research. I mean, as you know, we looked at age and comorbidity, and whether if we adjusted for that, that would account for any potential difference, and we could adjust for the appropriate optimal radiotherapy utilisation rate. There's been studies from overseas looking at the proportion of older patients receiving referrals into the specialist team. So obviously suggesting that if a patient didn't receive the referral, the radiotherapy utilisation rate would be less. There's less data on caregiver availability. I think it'd be great to look into other areas and other potential causes for reduction in the radiotherapy utilisation. I think also, often some of these referrals might originate from, potentially GPs. So it's education across the spectrum. And I think the radiotherapy treatment techniques have improved so much, even over the last 5-10 years, that the side effect profile is much better compared to days of old. So I think we also need to continue to educate our patients and the teams, the multi teams that we work in, to educate them that, oh, look, we expect you to tolerate this treatment well. Saying that, I've talked about breast cancer treatment, which is pretty well tolerated treatment. The main side effects is probably skin side effects and fatigue. But for patients, for example, having head and neck treatment, which might affect their swallowing function and eating and drinking and lead to deconditioning, the decision-making process can be a little bit more complex there. In terms of other risk groups, no, I don't think there's been much data that I'm aware of for older patients with cancer, but I think definitely be a great area to look into and to see if there's any other reasons and other areas that we need to address.
Yeah. And the other thing I was going to ask about, I guess, there seems pretty clear evidence that a comprehensive geriatric assessment is, useful and actually saves downstream costs. But as we always know, that's difficult for the decision makers, because if you save a bed in hospital, Penny, some other doctor will fill it up. So it doesn't translate really to a reduction in cost for the health system. But I'm wondering, how to make that argument, or do we need to think about other ways to get that information? And this frailty index, is that a suitable substitution? I mean, it's different, but...
Yeah, no, it's a really good question. I think it's very disappointing. We have level 1 evidence. If that was a, chemo trial or a radiation oncology trial, it would be implemented straight away. So it's disappointing that we have this high level data, well conducted, randomized studies, and it's not being incorporated. The clinicians are keen to do this. I think with resource limitations, unfortunately, across health, I'm not sure if that's possible. There are many different models around the world for geriatric oncology. There's a wonderful trial that was performed in Singapore. It was the Golden Study, whereas a dual or concurrent clinic appointment, so the patient would see the medical oncologist and also see the geriatrician, and the geriatrician will continue to see the patient during their chemotherapy journey and provide ongoing support. There's other models. Personally here, I refer older patients to the geriatrician. We've got a wonderful geriatrician team here, but that's not a standard process. We are trying to establish a geriatric oncology clinic. Monash has a wonderful geriatric oncology clinic, but it's not standard across all cancer centres in Australia. Is frailty index a reasonable surrogate? We need to do more assessment for older patients than is what's sort of considered standard initial consultation. So I think if you're doing G8 score or doing a frailty index, it's great that there's something more that's been done. I think if a geriatrician could be involved in the care of all older adults, that would be wonderful. But I think we need to do something more to assess the older patients versus a 75-year-old patient being discussed in a multi-team meeting and being presented and saying, oh, the patient's otherwise well, which is what does that mean? So I think using these tools does help, but it'd be wonderful to have more funding for geriatrician support for older patients with cancer. Maybe Tracy, in your role as director of NARI, you could take care of that for me.
Well, yeah, I mean, I think, with an ageing population, obviously the demand for geriatric care is only going to increase, and then age by itself is a risk factor, isn't it, for many cancers? So this is an increasing problem that we have to sort of think about how to manage. And there's some interesting I guess, things coming out around the use of AI to actually look at clinical notes and the conversations and generate a CGA. So, maybe technology will help in the future with some of this. There's just a question from David online there about, is there a reluctance to include clients over 70 in cancer radiotherapy studies due to the confounding factors of the other comorbidities they might have with age? So, just saying, is it easy to study the impacts on younger clients with cancer that have no other comorbidities present?
Oh, yeah, look, I think that was certainly the historic mindset. The inclusion criteria is patients that were well, minimal other health issues. I think we are improving now in terms of eligibility criteria, and sometimes it might be life expectancy based. So instead of 18 to 70 years and above, it might be, life expectancy greater than a certain amount. The more recent radiotherapy studies sometimes don't have that top figure in terms of eligibility criteria, so things are improving. But yes, competing, risks are certainly, potential concern. But I think now often it's more pragmatic or using life expectancy. And certainly with more of the recent stereotactic trials, stereotactic radiotherapy, which is even less sessional attendance is required for radiotherapy, it might be a life expectancy in terms of the eligibility criteria versus a certain age.
Mm-hmm. And I was going to ask too, which reminds me now that David has asked that question, is, clinical trials are hugely expensive and difficult, and some of one of the studies you showed is quite small sample, actually, one of the over 70s studies. So what's the role of registries? Or, because I know you use registry data in your research, and how do we improve, I guess, registry data so that we can answer some of these questions without having to go to trials?
Yeah, look, I think it's a great opportunity. We're very lucky here in Queensland. Cancer Alliance Queensland have a wonderful what they call oncology repository. So cancer registry data and treatment data, and quite comprehensive surgical, medical oncology and radiation oncology treatment data. So I think that's potentially a great opportunity, which is what we have used for electronic frailty index, which is being peer reviewed at the moment. Our manuscript for that. So I think that's definitely another option for clinical trials, especially say in the current funding climate. So I think we do need to consider all options, and I think that's what they're also considering for general oncology studies at the moment too. Level 1 evidence, multiple randomized control studies. It can be quite challenging. So yeah, looking at registry data could be quite helpful as well. So I think it's definitely one of the great options that we have moving forward. If we've got the data, we can assess the data for our patients. Yeah.
Yeah, I think the challenge with registries is always, getting perhaps patient-reported outcomes in there as well, to sort of supplement the information. It's a little bit more difficult. Is there any other questions people have? Oh, we've got Penny here. No, I don't think they're done. So we'll have that recording done and posted up in the next few days. So thank you very much, Penny, for coming and joining us today. And yeah, please join me with your clap reaction. And I'd like to invite you all to join us for the next seminar on ageing on 18th of August. And I'll be featuring Dr. Nanelle Kenny, who'll be presenting on home care packages and decision making. And thank you everyone for your ongoing support. Dave, do you want to ask that last question while we've got Penny here? They've just put up a question that says, in your experience, what are the biggest misconceptions about treating older adults with radiotherapy, either among clinicians or patients?
I think that we have many more options than we used to in days of old. So as I mentioned before, instead of a patient needing to come to 5 or 6 weeks of breast cancer treatment, we've got data now that a 1-week course of treatment is sufficient. Similarly, for patients with head and neck cancer, that used to be 6 or 7 weeks of treatment. Again, we've got more recent data that 4 weeks, having 2 weeks of treatment, a 2-week break, and then 2 weeks treatment is appropriate. So there are different options for older patients, and altering schedules We don't have data that the radiotherapy side effect profile is high in older patients in terms of radiobiologic side effects of radiation, but it's a functional reserve or physiological reserve for older patients. So if you can appropriately support patients on treatment, patients are well supported by the multidisciplinary team. Patients are suitable for radiotherapy. So I think if you're not sure whether a patient should be referred or not, I think a conversation and referral so they can be considered for treatment, and the patients can assess what their preference is for treatment.
Right. Well, thank you very much again, Penny.
Thank you.
Yeah. Cheers, everyone.